Great. Awesome. Welcome everyone to Strengthening the Ribbon, a primary care approach to eliminating HIV/AIDS in Indian country. This is the first session of an interactive three-part series that will provide a special focus on providing support and resources to the frontline practitioners fighting to eliminate HIV/AIDS in Indian country. The series will also provide forums for participants to learn about and discuss innovative resources and best practices and the reduction of stigma in the community, providers, and support systems, and emphasize increasing outreach and testing services and hearing the stories from the front lines of our urban Indian communities. My name is Divya Nanduri, and I am the Technical Assistance Manager with the Technical Assistance and Research Center, also known as TARC, at NPAIHB. Joining me from the NPAIHB team are Kayla Emmerich, Public Health Associate, and Rachel Dio, Communications Associate. We are honored to have you all here today. We kindly ask that you place your name, organization, tribal affiliation, and title into the chat box. In addition, we welcome any feedback you would like to provide about your webinar experience in our survey, which is also posted in our chat box. Next slide, please. Today, NPAIHB is collaborating with Indian Country ECHO to provide insight into integrating clinical interventions and treatments for addressing and eliminating the HIV/AIDS epidemic and supplement existing knowledge on ways providers can support HIV/AIDS care and treatment provision. Next slide, please. Before we continue, I would like to bring your attention to a brief disclaimer that this event is made possible by the Minority HIV/AIDS Fund through the Indian Health Service. Next slide, please. And as shown in this agenda, we will begin the session with the session overview and some housekeeping, followed by an introduction to our wonderful presenter and the presentation. We will end the session with the Q&A session and adjourn promptly at 3 p.m. Eastern Daylight Time. Next slide, please. For those of you that are unfamiliar with NPAIHB, here's a little background. The National Council of Urban Indian Health, also known as NPAIHB, is the national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NPAIHB is the only national representative of the 41 Title V urban Indian organizations, or UIOs, under the Indian Health Service in the Indian Health Care Improvement Act, or IKEA. NPAIHB strives to improve the health of over 70% of the AIAN population that lives in urban areas supported by quality, accessible healthcare centers. Next slide, please. As we dive into our session, here are a few things to keep in mind. The session is being recorded. All mics have been muted unless otherwise directed. Questions can also be typed into the chat box and we will address them as we see. And a Q&A session will follow at the end. And to receive CE hours, please complete the survey using the link that will be provided in the chat box. And please note the QR code at the bottom of the slide. You can scan this with your phone to access our feedback survey. Next slide, please. To ask a question, first select chat at the bottom of your Zoom screen, then type your question or comment into the chat box that will appear on the right of your screen. Next slide, please. I will now introduce our presenters for this session, Dr. Jorge Mera, David Stevens, and Jessica Leston. Dr. Jorge Mera is the Director of Infectious Diseases for Cherokee Nation Health Services, the largest tribally operated healthcare system in the United States. He completed his fellowship in infectious diseases and clinical microbiology at Baylor College of Medicine in Houston, Texas, and is board certified by the American Board of Internal Medicine in infectious disease. During recent years, Dr. Mera's efforts have been dedicated to organizing the Cherokee Nation HCV Elimination Program, as well as the HIV/HCV ECHO Project. He is also the director of the HIV Clinic since 2012 and the principal investigator of the End the HIV Epidemic for the CNHS. He's a clinical assistant professor in the Department of Internal Medicine of the Oklahoma State University Health Science Center and a fellow of the American College of Physicians. Jessica Leston is a clinical programs director at the Northwest Portland Area Indian Health Board, where she focuses on systems and policy change. She began her public health career working at the Alaska Native Tribal Health Consortium in 2004 and has worked in tribal health since then. She believes strongly in learning from traditional indigenous ways of knowing to help guide, direct, and strengthen our public health systems. Her mother's side of her family are settlers to Turtle Island, originally from Germany, Sweden, and Ireland, and her father's side of the family is originally from Austria, Finland, and I apologize, from British Columbia and Southeast Alaska. She grew up in Chicago, but spent many summers in the Southeast Alaska with her grandmother's family, climbing Deer Mountain, picking huckleberries around Ward Lake, and watching the salmon make their way to the Ketchikan Creek Falls. In her life and work, she honors the Alutiiq cultural values. We are responsible for each other and ourselves. David Stevens is the Echo Clinic Director for the Northwest Portland Area Indian Health Board. He began serving the 43 tribes of the Northwest Portland Area Indian Health Board 10 years ago, focusing on developing and implementing technology-based health interventions. In his role as Echo Clinic Director, David supports telehealth services for clinicians serving American Indian and Alaskan Native communities and focuses on the development and implementation of technology-based health interventions. David's mother's family are settlers from Sweden, Norway, Holland, and Scotland, and his father's family is Haida, as well as settlers from Scotland, Wales, and Ireland. He is the son of a tribal health director and a school bus driver, partner to a neuroscientist, father of a lively 3-year-old, and a nurse with a passion for finding creative solutions with less money, fewer staff, and less fanfare, while making sure friends live up to their promises. All right, next slide, please. So before we dive into our presentation, we're gonna have a quick pre-knowledge check for you all. So we'll have a poll pop up on your screen in just a few seconds. All right, and please answer these questions within the next 30 seconds with the best answer. All right, thank you so much for your wonderful answers. Great, and we will now turn the floor over to Dr. Mera. So let us welcome Dr. Mera by placing a heart emoji in the chat. Heart emojis, applause, all the good things. Thank you, thank you. Dr. Mera, the floor is now yours.
Thank you, and it's a pleasure to be here today. Very excited to talk about HIV and in the context of the pandemics that we're living. But I believe that Jessica or David are going to cover the first few slides, so I'll give the word to them first. Next slide, please.
Amasa, everyone. Meet Jessica DYU. My name is Jessica, and I'm really happy to be here and share knowledge and hopefully receive knowledge back from everyone on the call. On everything that we present today. My small portion, just 2 slides besides syphilis, are around an Indigenous HIV, hepatitis C, and STI elimination strategy that we're working on with the Indian Health Services HIV, STI, and hepatitis C program. We will call it the Indigenous for short. So we've been working with 17 individuals or 18 individuals across Indian country for the past year to help develop an Indigenous strategy for elimination of these diseases, to go alongside, to walk alongside the national HIV, STI, and HIV strategies, where they're all separate, and also the ending the HIV epidemic. So what we have come up with, this is just 2 slides worth of information, but the core values and principles that we wanted to incorporate into the strategy include storytelling and sharing wisdom, community, family, interconnectedness and relationships, balance, harmony, healing, affirmation and community strengths, hard work and humor, courage, diversity, equity, justice, honesty, trustworthiness, with an overarching love, respect, responsibility, and reverence for everyone participating in these efforts, community to healthcare providers to tribal leaders. And so by using those principles and taking this concept of the medicine wheel throughout, which represents, all of the different areas and nations, from those that are deciduous forests, pine forests, pine trees and from cactuses, although we know that they're not trees. We had a long discussion about it. It's just most representative of the Southwest. So next slide. We decided to move forward with key learnings that were going to walk us along with all of the other national plans. And those learnings are very different from the national plans because they include sovereignty and how we are addressing these epidemics with sovereignty of design and delivery, cultural responsiveness, ensuring that how we respond to the unique elements and teachings of all of the cultures in which we serve, partnerships not only within the healthcare systems in that we work, CHR is partnering with public health nurses, partnering with medical staff, partnering with pharmacy, but also partnerships across different public health systems, partnering more and strongly with the state, with national efforts and with other tribes. Also awareness, increasing the community awareness, not just of HIV, STI, and hepatitis C, but of the relationship between sexual health and overall health and well-being that's used to just support the prevention and treatment of the epidemics. Supporting capacity to provide care, hopefully working with community health aides, community health representatives and educators to increase their role in responding to the epidemics, addressing stigma and implementing real strategies that address stigma, diversity, and inclusion, and then finding ways to enhance the data systems that we have while we wait for new data systems. So figuring how to better track, care manage patients and sites, developing our own research initiatives, and implementing evaluation to address the information gaps and other clinical gaps that we would see from constant evaluation. So this is something that's going to be coming out in September around the US Conference on HIV, AIDS, and Hepatitis that will be happening in Puerto Rico. I believe you can attend in person and also virtually, and we will be sending this out to all of our partners in Indian country once we have it finalized.
Okay, thank you, Jessica, and thank you for paving the way to the presentation. So, although we will be focusing a little bit more on HIV in the next 45 minutes, it's important to put it in the context of this endemic that we are living, which encompasses several epidemics that are outlined in the slide. So we'll start with a clinical case. Next slide, please. So, and this is a real case that we had in our services several years ago. So this is Mr. S, a 24-year-old American Indian Alaskan native who suffered a right femur fracture 6 years before he saw us. Unfortunately, pain management training or policies were not available in the institution that cared for him after the accident. And he was discharged from the hospital with oxycodone hydrochloride for pain control. 2 years before we saw him, his new medical provider refused to fill the oxycodone. And I will not criticize him for that because we shifted in America from giving everybody narcotics to nobody gets anything. And there is a middle ground for everything. But when you need to take narcotics away from a patient, you need to make sure you address the patient's needs. And this was not done in this case. So unfortunately, the provider was not trained in screening for substance use disorders, nor did he have an MAT waiver. So the patient then turned to his friends to get his pain medication, but later he had to purchase it in the streets. And this is for all of those who work in the trenches, this is like a daily story that we hear. 1 year ago, one year before we saw him, he started injecting heroin since it was much cheaper than buying the pharmaceutical pills. And unfortunately, syringe service programs were not available where he lives, and he started sharing needles and syringes. So 3 days before he presented 3 days before we saw him, he presented to the emergency department with opiate withdrawal, nausea, vomiting, diarrhea, abdominal pain, etc. But fortunately, for the first time, he meets a provider in the ER that was trained in substance use disorder management and induced him with buprenorphine naloxone and gave him a 3-day prescription, enough so he could get to our clinic and be evaluated as an outpatient. In addition, the ER provider was also trained in STI screening and HIV prep, and during the ED visit, he was screened and tested positive for HIV. HCV was negative, other STI screens were negative, and he was referred to primary care, but ended up in our clinic for HIV evaluation and treatment. Next slide, please. So there were several missed opportunities in this case, which I kind of highlighted some of them. First, the orthopedic surgeon did not recognize that opioids are not the first line of treatment for management of pain in the outpatient setting. Maybe in the acute setting they are, but not when he was discharged. And the patient's primary care provider did not recognize that the patient had a substance use disorder and just got him off the narcotics cold turkey. Then the health system failed because they should have guidelines and policies in place for pain management. They should have policies in place for medication-assisted treatment, and also for screening substance use disorder, HIV, HCV, and STIs. And again, society failed this patient because we did not have syringe service programs available at that time because they were illegal. And so the patient is just falling through the cracks at each point of care. So in summary, we should not be relying on luck for patient care or on fortune for patient care. Next, please. So what can we do for mistrust from the 3 different angles? As a primary care health worker, as a health system leadership, or as a society? And I'm going to try to cover a little bit of those. Next. Next slide, please. So I'm going to give you the example in the next few slides of an outbreak that we want to avoid where we work, which is the HIV hepatitis C outbreak that occurred in Indiana. But before I go there, it's important that we understand the concept of a syndemic. And the syndemic has 3 principles. First, it's clustering of 2 or more conditions in a specific population. And this could be hepatitis C or HIV or substance use disorder. These are epidemics by themselves, but when they meet, they synergize and produce excess burden of disease in a population, meaning the bad outcomes from these 2 epidemics that combine are worse than the outcomes from each epidemic in itself. And that these are precipitated and propagated by other large-scale factors, which are behavioral, structural, and social forces that collide in a negative way and favor that when one of these epidemics hits that area, they propagate more easily and synergize with other epidemics. Next slide, please. So you can see here in the graph that you have these, can you go back one, please? You have these social, structural, and behavioral factors in a negative way. And then when one of these epidemics hit the area, they may collide with the other ones and synergize to produce really bad outcomes. And one thing that I left out of here, which I should put on my next presentation, is COVID, because COVID ended up harming making worse everything that we were doing to try to mitigate all these epidemics. Next, please. So looking at it in another way, as a clinician, we are used to seeing diseases in the surface, like the tip of this iceberg. We see hepatitis C, HIV, STIs. Can you click once more, please? But actually, these conditions are not the problem. They're just a consequence of other situations, and like in this case, substance use disorder or risky behavior. One more click, please. Which again are not the problem in itself. Go ahead and click all the way before you jump in the next slide, please. And but all these are driven by these factors that do not pretend to be completely all-inclusive. There's others, but these are the main ones, which is access to care, poverty, domestic violence, mental illness, historical traumas, very important in Native American communities, as well as cultural disconnection, incarceration, and others. Can you do several clicks? A little bit more, one more. So as clinicians, we surface the iceberg, we screen, in the best case scenario, we screen, link to care, and provide the best quality of care that we can. But unless we intervene in preventing all these drivers that lead to the tip of the iceberg, we're really not going to get rid of these epidemics or syndemics. We can just put a patch on them transiently. And sometimes that is the best we can do, and we do it because we do decrease the harm, we reduce the harm, but we cannot eliminate them completely. Next slide, please. Okay, let's go to the Indiana outbreak. In Austin, Scott County is one of the worst counties in Indiana when you look at ranking by health and social indicators and life expectancy. And from 2004 through 2013, they had less than 5 HIV infections reported annually in Austin. In 2014, suddenly a provider noticed that he had diagnosed 3 cases of HIV in a very short period of time. And he linked that these patients were related in some ways, which was the sharing of needles. So he reported to the Indiana State Health Department, and they started doing contact tracing, and they identified by mid-January 8 more individuals, and the source of infection appeared to be injection of an opioid, which is oxymorphone. And by June of 2015, they had detected 170 new HIV infectious and 115 co-infected. 115 of those 170 were co-infected with hepatitis C in a small community of 4,200 people. And all these infections, when they were analyzed using molecular epidemiology, were tracked down to one single HIV strain. Next, please. So the social structural factors that were in place in that county were high poverty rates, unemployment, lack of education. Very few had gone into college, and 20% had no high school education. There was almost no awareness of HIV in that population and on how HIV was transmitted, et cetera. Syringe service programs were not permitted by state law at that place. And there was no HIV or hepatitis C care available, and very limited addiction services, including the lack of medication-assisted treatment. So the State Health Department and the CDC intervened in this outbreak to mitigate it. Basically, they made 2 major interventions. One was a one-stop shop, meaning a patient could go to a specific geographic place in which they would receive behavioral health treatment, hepatitis C, HIV, medication-assisted treatment, and also be given clean needles and syringes. And I'm talking about I mentioned the word clean because I'm talking about needles and syringes. I'm not talking about humans. Also, the most important thing is that the governor at that time made an emergency use authorization for syringe service programs. And you can see on the graph below that where that arrow is when the SSPs were, syringe service programs were authorized, and the outbreak was aborted basically after they did that. Next slide, please. So on the left, there was a publication in New England Journal of Medicine in 2015 with all the actions that should be taken to prevent or mitigate these problems. And I'm not going to go over the list. You can read it at your leisure, but it's all things that make medical sense. But 4 years later, in 2019, the same journal, an editorial said 4 years after the United States received the wake-up call about the importance of harm reduction, the most vulnerable areas of the country remain asleep. And despite the federal government's goal of ending the HIV epidemic in the US, it is not clear that this will do what is necessary to address the spread of HIV and hepatitis C in rural America. Health professionals can advocate for legal changes that authorize syringe service programs and other life-saving interventions. And I think there has been some progress in the last 4 or 5 years, but not in the intensity that we needed to actually mitigate this endemic. Next, please. So now let's talk about the HCV, SUD, STI epidemic in Indian country. So when we look at HIV, then in the left, you can see that the HIV infections have increased since 2014, year by year in Native American populations. But what is really disturbing is when you look on the graph on the right that over 40% of the HIV infections related to that in the female Native American population, 47% of the diagnosis of HIV can be tracked down to injection drug use as the mode of transmission. And when you look at the Native American population as a whole, compared to other ethnic groups, they have the highest rates of HIV attributed to injection drug use. And this is an alarming sign and problem. Next, please. When you look at the number of cases of congenital syphilis reported per year, they have been dramatically increasing in the last years, and the graph is pretty outstands for itself. The next slide, please. And when you break this down by congenital syphilis rates per 100,000 live births, Native Hawaiians and American Indians have the highest rates in the United States compared to any other ethnic group. The numbers, just FYI, the numbers in the columns are the number absolute of cases, but the columns are graphed based on rates. Next, please. And when we look at hepatitis C, this map on the left, what it shows is the American Indian and Alaska Native as a percentage of county population in 2010. Hopefully we'll have the 2021 soon. And the greener the areas, that means there's more Native American people living in those areas. So you can see it's very concentrated into the western part of the United States, being California and Oklahoma with the highest Native American population. And hepatitis C disproportionately affects Native Americans, and mortality, it has the highest incidence, mortality, and rates of chronic liver disease compared to white population or other ethnic groups. One more click, please. And as you can see, Native Americans are concentrated on the West. And I don't have the slide here, but when you look at hepatitis C elimination programs, they're mainly concentrated on the eastern part of the United States. So there's a mismatch there on the efforts to eliminate hepatitis C and where the Native American population resides. Next. So what should the primary care provider know about HIV to help mitigate this, this endemic? So first, a couple of basic concepts of HIV are needed, knowing what preventive strategies you can implement, knowing who and when and where to screen, and also when you run into a patient that you've diagnosed HIV for the first time, what do you do with that patient? Those are the basic, I think, concepts that a clinician, being a nurse practitioner, physician assistant, or physician should know. Next. So a little bit of some basic concepts on HIV. HIV transmission is basically through blood, semen, vaginal secretions, and breast milk that come into contact with other mucous membranes, damaged tissue, or is injected in the body, either through sex, that can be vaginal, anal, or oral sex, or contaminated needles that can happen sometimes, unfortunately, accidents in the healthcare setting, but usually it's through injection drug use, intravenous injection drug use. And also there's vertical transmission from mother to child. Next, please. So we do know that HIV is not transmitted by casual contact, by working in or playing with an HIV positive person, by kissing, shaking hands in public schools, and hugging, in a public toilet. Air, food, or mosquitoes do not transmit it. And even if you're HIV positive today, if the patient's taking antiretroviral medication and it's virally suppressed, undetectable means untransmissible, so you cannot transmit HIV if you're virally suppressed through medications, which has been a great advancement, in the care of HIV positive patients. Next, please. So the HIV virus infects the CD4 cells, which is a subset of our lymphocytes. And these are lymphocytes that are very important in preventing infections and protecting us from tumors. And if you look at, as time goes by, the CD4 cell counts get destroyed, the CD4 cells get destroyed, and the count starts going down over a period of months to years. But the virus continues to multiply and increases in concentration in the human body. Now that can be prevented by treating the patient with antiretrovirals. Next, please. So at the beginning, most patients who are infected for the first time will have, sometimes they will have symptoms when they acquire the infection, but most of the time it goes unnoticed, or the patient doesn't pay too much attention, or the provider does not identify them as being related to HIV. And the patient does well for several years, and then it starts, some problems start appearing, usually when their CD4 count starts dropping below 200. They can start losing weight, having mouth ulcers, etc. And after several years, the patient immune system is very depleted, and he is exposed to opportunistic infections and to tumors. And without treatment, they will succumb to this disease. And the average time that this may happen is 5 to 10 years. Next slide, please. So it's also important to understand that the complications that these patients have is related to the number of the CD4 cells they have in their blood and in their body. So when a patient has more than 500 CD4 cells, usually they won't have many different problems than people who are HIV negative, except for a higher rate of tuberculosis. But when the CD4s drop between 200 and 500, tuberculosis continues to be more prevalent, and they have fungal infections. And you can go down the list as the CD4 drops, you start getting more complicated and lethal infections that if they are not treated, the patient will die. And on the left, you have a graph of the different parts of the body and where the different opportunistic infections or tumors take their toll. Now, we are lucky today that we don't see this very often. I always tell the young people, in 1985, I was doing my residency in our hospital wards, 50% of the patients were AIDS patients. And most of them would be dead, unfortunately, in 6 or 7 months after their diagnosis. But that has changed due to antiretroviral medication. Next, please. Today, the life expectancy is almost the same, not exactly, but it's almost the same for an HIV positive patient if they take their medications. So the other situation is that many of these patients, when they get infected, they do have symptoms, but either they don't pay attention to them or the provider doesn't recognize them. So symptomatic illness, according to the literature that you read, is from 40 to 90%. It's non-specific. It appears 2 to 4 weeks after you're exposed to the HIV virus. And usually in 1 to 4 weeks, it goes away. Very similar to syphilis. You have some lesions, you may or not pay attention to them, but even if you don't treat them, they go away by themselves initially. Next, please. Next slide. And these are just a list of the different types of symptoms that the patient, can you go back one? One slide back. So this is a list of symptoms that the patient may experience or organs that are affected. And as you can see, they're very non-specific because, fever can be due to many things. Pharyngitis could be attributed most frequently to viral or streptococcal. Rashes are common. Muscle pain, especially in the COVID era. I mean, you couldn't differentiate this from COVID. But if anybody presents with a specific rash that is that you don't know what, I always tell the students, if you see a rash that you cannot be certain of what the etiology is, think HIV and think syphilis and make sure you rule those out. Next, please. Next. So prevention, I started with prevention because we should do that. We should prevent, screen, and treat and do all at the same time. But if I had to choose one, let's prevent, because if we prevent, we wouldn't need to screen or to treat, right? Because nobody would be positive. So HIV PrEP is when an HIV negative individual at high risk for acquiring HIV takes a pill a day to lower their chances of getting infected if they are exposed to someone through the sexual route or through the injection drug use route. It's important to understand that this pill is not a substitution for other HIV prevention interventions such as education, use of condoms, behavioral risk reduction, et cetera. It should complement them. And it doesn't protect you against other STIs. It's basically against HIV. And it's not the same. PrEP is not PEP. PEP is for post-exposure prophylaxis, after you got exposed, not before you got exposed. Next. So the critical thing about PrEP is how do you identify the patients that need PrEP? Next slide, please. And so the only way, well, not the only, I hate to say the only way because there's always many ways to do something, but a major way is to take a sexual history. And the major problem with taking a sexual history is that most providers don't have the time to take a sexual history unless they assign that visit, if it's a follow-up visit, to taking a sexual history. And I think that's what I usually advise them. You can't, it's very difficult in a 15-minute encounter of a diabetic patient to inject a sexual history visit there. So one way of doing it is just having them come in for a sexual history and addressing all these risks. And it's very important to address this because it provides valuable information to educate the patient, and so the patient can educate their partners or peers in the same way. The important thing is that you need to tell the patients that the questions that you are asking, you're asking them to everybody, regardless of their age, gender, or race. It's just part of your routine. Next, please. So I want to show you a simplified version that we use here at Cherokee Nation in our clinic specifically, because sometimes it's difficult on how to start. So you just tell the patient, I'm going to ask you a few questions that I ask everybody. I just need to use for you to answer yes or no. So the first one is, have you ever injected drugs? Have you injected drugs in the last 6 months? And if the answer is yeah, that patient needs a PrEP evaluation. If the answer is no, you go to the next question and ask them, do you have sex with women, men, or both? And if they say no, then you're done. No injection drug use, no sex with anybody, you really can't get HIV. But if they say yes, you go to the next question, and during sex, do you use condoms? If they say all the time, then you're done. The patient doesn't need PrEP. And if it's sometimes or never, you go to the next question, which is the person you have sex with, is it the same person all the time? And do you know their HIV status if it's negative? And if it is negative, you're done. And if not, the patient may need PrEP, at least offer them PrEP because they're either injecting drugs or having non-protected sex with multiple partners that they don't know their HIV status. This is just one way we do it. You won't find this in the literature because we just made it up, but it works for us pretty well. There's a lot of stuff in the literature that you can use. Next slide, please. Next. So when to screen Native Americans, this applies not only for Native Americans, but for any individual, is at least once in their lifetime and more often based on their risk. So if someone's injecting drugs, we screen them every 3 months. If someone is, depending on the risk of the behavior, we may screen them every 6 months or every year. But at least once in a lifetime should be done. Next, please. So screening strategies, if you wait for the patient to go to the primary care provider and get screened there, and that's all your screening strategy, you will probably screen 20% of the whole population, because not everybody has a PCP, and not everybody who goes to the PCP gets actually screened for HIV. So there's many strategies. These are just some of them. Use your electronic health record reminders to remind the provider, no matter where the patient is, PCP, urgent care, emergency department, a surgery clinic, anywhere they hit, have the reminder pop and alert this patient needs this screening. Lab trigger screening, I'll explain in a second what it is. And then community outreach. Even if you screen everybody that comes to your system, there's still going to be about 20 or 30% of the patients who do not access your system. You have to go out and reach them. Where High yield areas would be syringe service programs, medication-assisted treatment services. We've done it in food distribution sites with a lot of success, mobile units, incarcerated persons, etc. You need to reach out to these areas and where there may be high-risk individuals for HIV. Next. And lab trigger screening we've been using here in Cherokee Nation for the last 5 or 6 years, and it's been very successful in identifying patients who otherwise would have been missed. Is basically a patient comes in, they're ordered a lab by a provider, any type of lab, a cholesterol, a CBC, an iron panel, etc. And we check if that patient meets criteria for HIV, or we do it for HIV and Hep C screening. And if they haven't been screened, we just, and they have an informed consent in the electronic health record that allows us to intervene, then we just proceed and drop a test. And we've identified many patients, especially with hepatitis C, but a lot with HIV that otherwise would have been missed and not identified early enough for treatment to be more successful. Next. So this is just the interpretation of these tests for HIV. Important to know that the first 10 days, 5 to 10 days after you're exposed, there's practically no test that will tell you that that patient's HIV positive. So if someone comes and says, 4 days ago, I had a potential HIV exposure, there's no test that day that will be able to prove that that patient got infected 4 days ago. Now, if he was previously infected, you will, but not in those 4 days. The first thing that pops up in your blood when you're infected with the HIV virus is the HIV RNA, then the HIV P24 antigen, and then antibodies, which are IgM initially and IgG later. The important thing is that the 4th generation tests include P24 antigen and include IgM antibodies in their panel. So they're pretty good in picking up the infection within 15 or 20 days after the exposure. But just remember that there are windows in which you may miss these patients. And you just have to repeat the test or do a different test. Next slide, please. So the 4th generation test, it's pretty simple. Like I mentioned, it includes a P24 antigen and IgM antibodies against IgM and IgG against HIV 1 and 2. So the test is negative. That patient, unless you caught him real too early, like 5 days after the exposure or 7 days after the exposure, that means that the patient doesn't have HIV. The test is positive. It doesn't tell you to which HIV virus it's positive, and you need to confirm this with a differentiation immunoassay. Usually the laboratory reflects this automatically. And then it'll tell you if it's HIV-1 or HIV-2, and if that's the case, then the diagnosis is confirmed. But sometimes it'll be negative, this confirmatory test. But you have a positive 4th generation test with a negative confirmatory test, then you need to do an RNA to make sure that the patient doesn't have HIV. But this is for HIV-1, which is the most prevalent strain in the US. For HIV-2, you would have to, there's a different pathway that I don't have time to go into the details, but this is for the majority of patients with HIV-1. Next slide, please. And you can, okay, let's go to the situation. We talked a little bit about screening. We talked a little bit about prevention. So what did you do when you diagnose a patient with HIV? And this could be an asymptomatic patient in which you were a really good screener and he tested positive and it's confirmed, or a patient who comes in with symptoms like hairy leukoplakia on the tongue or oral thrush or a rash that you suspect to be HIV. You do a test and it's positive. So you have a positive patient, you confirm the test. Next slide, please. So what should you do? The first thing is you need to order a bunch of labs that will help you evaluate the patient, but the labs that you must order on that day 1 is a CD4 count, a genotypic or phenotypic resistance, and a CBC and a CMP and a pregnancy test. That's all you need on that first day, and you can probably start treating the patient empirically for the majority of patients with that, as long as you have drawn those labs and send them out. Now, if you have time, you order all the labs that are here that I'm not going to go into detail that will cover all the needs for future evaluation of that patient. But the goal is that a patient that gets diagnosed on day one gets treated on day one, and then you can refer them to a specialist who will confirm if your treatment was appropriate or not. But even if it was not the best treatment, a specialist has time to change it and correct without any harm done. Next slide, please. So the goals of therapy is to suppress the viral load so that patient will not infect other patients, and that patient will have a wonderful, healthy life, not worrying about HIV. Next. And when you look at the guidelines, there's really two treatments that you can use on day one, and I'll just list them here. I won't go into details because I don't have much time, but the first one is a 1-pill regimen, and you can make the diagnosis, start the treatment, and then refer for a specialist, or you can do it yourself if you have enough training, which is not hard to obtain. Next. I'll skip this one. Next. And these here are the 4 pillars of ending the HIV epidemic, which kind of summarize what we talked about: screen, prevent, treat, and respond. Next slide. Next. This is just to remember that we had a case when we started. Next slide. So what can we do for Mr. S? We need to recognize that we have a problem that's a syndemic issue, and that we have to have policies in place to address all the epidemics within the syndemic. We have to enforce these policies, and we have to allow our providers and our clinics to train and to participate in these activities, or else it's impossible to do. Next slide, please. As society, we need to make sure that we address all those social determinants of health, and make sure that we have syringe service programs, that we have mental health services, that we have substance use disorder services, MAT, etc. Next. And as a provider, even if the society fails you, or if your health system fails you, you can still do a lot of things. You can vaccinate the patients. You can get a license and prescribe MAT, and I think you don't even need that now. You can learn about how to treating a patient with HIV, like I just mentioned, the basic labs you need to do and how to start them on treatment. You can learn how to deliver PrEP. You can learn on education on how to teach your patients on safe injection practices, and you can advocate for syringe service programs if you don't have them in your area. So there's still a lot that a provider can do, even if their health system or their society where they live fails them. Next. But you're the last resort between that absolute failure for that patient. You can still help them. And I think I'm out of time, but I just want to mention here that it's very important to address those structural, social, and behavioral factors, because if we don't do this, we're only going to be prescribing HIV pills the rest of our lives, and we will not be able to, eliminate these epidemics, which is our goal. So we do our job in our end, but other people need to do their jobs on their end for us to be able to solve these pandemics. This syndemic. Next. Next slide. So in conclusion, ending the HIV, SUD, HCV, STI epidemics will be difficult if you don't embrace it as a syndemic. You need to modify all those factors that I mentioned, structural, social, and behavioral. And you need political leadership, support, and will. You need to integrate your services as much as you can and not tackle these diseases individually. And primary care providers should be at the forefront of harm reduction, STI, PrEP, HIV, and hepatitis C treatment, because if they don't do it, nobody will do the job for them. I think that's my last slide. Okay, the last is just resources. If you want to learn how to do all these things, if you don't know them already, you can join our ECHO community. And we provide training, and we provide ECHO sessions in which we give you advice on how to treat all these disorders that I just mentioned. Next. We have an Indian country ECHO, and there's the link for you to get more information. Next slide. And thank you.
Great. Thank you so much, Dr. Mera, for that presentation, and David for posting all those links, and Jessica for that wonderful introduction as well. We will definitely be posting all these links as well as we send out our follow-up emails, and all of these slides, as well as the recording, will be available on our website and in the follow-up email as well. So the floor is now open for any questions or comments you would like to ask. We'll give about 5 minutes as well. And as you are all thinking of your questions, posting them in the chat box, we will also pop up our post knowledge check poll, so you can answer those as well. But please feel free to come off mute, turn on your cameras, and ask those questions. Great. Let me just check the chat as well, because I saw some items come up throughout.
I would say just in follow-up to the conversation around engaging with HHS and congressional leadership. You know, obviously, most of that needs to take place at a government-to-government level. So raising issues related to HIV and STIs and hepatitis C could really be strengthened if, you know, brought to a priority level in your tribe, in your tribal clinic, in your area health board, in order to advocate at different consultations around these issues as well. And those happen relatively frequently. And I think we have some white papers on HIV and Hep C and STIs. If anyone, you know, wanted some place to start, I'm happy to share what we have. I'll put my email in the chat.
While folks are thinking about questions as well, just huge thanks again for allowing us the opportunity to share. And I think just like Dr. Mera mentioned, the diagnosis of HIV, SUD, HCV, and STIs are just the tip of the iceberg. We really hope that this presentation is a tip of the iceberg for really diving in to learn how to prevent, screen, and treat all these various epidemics, and invite you to join us on any of the Indian Country Echoes, which are our 1-hour telehealth sessions, where we really hope to provide a space for clinicians and all others interested in learning how to address the epidemics, to ask questions, learn more, engage in a didactic, and really join a learning community of participants who are really passionate about ending these epidemics, and shared the link in the chat for the infectious disease echo, but invite you to email myself or email me any questions that you may have, or any echo programs that you'd be interested in joining, and happy to connect you to the various Indian Country Echo programs.
Thank you for that. And thank you so much, Jessica and David, for providing your contact information as well. We'll be sure to share that as well in our follow-up emails. Any questions? I see that Summer had asked, will the slides be available? Yes, we'll be providing slides as well as the recording for this session. And another comment in the chat from Karen, I may have missed it if you addressed it earlier. STIs are reported to our state health department here in Colorado. Is that a national requirement? I don't know if anyone here can speak to that.
Yeah, it's a CDC, it's a national CDC requirement. So not only are clinics reporting to the state, hopefully, but any lab is reporting to the state as well. So if you have an in-house lab, they are supposed to be reporting to the state, or an outside lab, they are reporting to the state.
I want to piggyback on that question and answer. So the question is, why do we report it? You know, what do they do with this information? And I mean, I'm sure they do a lot of analysis of the data, but one thing we should make them accountable for is for contact tracing. Because if you just give the data, nothing happens. I mean, it will be nice for someone to publish a manuscript, but other than that, it's not really improving the outcomes in your population. And what we desperately need is contact tracing, not only on syphilis, but on HIV, on hepatitis C. And some health departments do a great job on it, but some are completely non-existent. Maybe it's not their fault. Maybe they don't have the resources. It could be many things, but it's someone that we have to ask for accountability for contact tracing. And after COVID pandemic, which is not over, but at least we're not having the surge that we had, a few months ago or a year ago, we built a very strong, solid contact tracing force, and we should use it for tracking down all the other individuals who may be infected with all these, diseases and don't even know it. And it's critical, for them to know it so they can get treated. I just don't want to miss the opportunity or the inertia to do that.
So I'm sorry if you can hear me, sir. I don't mean to interrupt you. So I'm Karen. I'm the one that asked the question. Part of the reason I was curious about that is because I don't always get information back about whether or not a partner was treated or whether a partner was even notified. And I get nervous about that because sometimes the patients will come back with a second infection or, and then they're saying, well, you never cleared it up. Well, we did what was recommended by the CDC. Are you still having sex with that same person? Well, so I'm just curious if there's any kind of required information or data that goes out somewhere that says, that person gets notified. You need to contact your partners and let them know. I mean, I know we can't enforce it, but I just think that there's they're not closing the loop because I don't know if the partner was treated. I will send them out with a prescription to give to their partner, but I don't always know what happens with that. And I see that mostly with like chlamydia and gonorrhea and stuff, but
I'm a big proponent of taking partner services like into the local clinic or tribe for that very reason. That's really the only way we can know if a patient has been fully treated, if they're going to like a state health clinic or something like that, and how to solicit partners. Just like Dr. Mera was saying, we had so many people doing such great contact tracing for COVID. We really need to be able to pull on that and re-implement that for other efforts. And I'm saying syphilis right now because the disparities in syphilis in American Indian, Alaska Native communities are unacceptable. And, there are variations in areas, but we are having babies dying because of congenital syphilis, and it's a sentinel health event. It should not be happening at all to anyone. And the cases of congenital syphilis in American Indian, Alaska Native babies are huge because of nothing that person is doing because of access to care, because they may be doing drugs and don't want to come in for treatment because they don't want their baby taken away for so many reasons. But to your question, the only way I think you can really follow full syphilis care management is either having a stellar relationship with the state in which they share all data with you. And if that happens anywhere, like, please tell me about it, or to just take that responsibility on locally.
Well, we've just started recently adding the hepatitis screening and syphilis screening to anybody who comes in for STD testing.
Yeah.
And a lot of them are not happy about it because they hear, oh, I can just pee in a cup. Well, not for everything. So I just, we're doing what we can. We're in a very large city. We do have, unfortunately, some of our patients are, IV drug users, but we haven't seen, knock on wood, we haven't seen a ton of HIV. But we have picked up just recently a kind of an uptick in syphilis, and it's been a little distressing. So thank you very much, all of you.
You will find it for syphilis for sure.
Okay, awesome. Well, thank you.
Great. Thank you so much. I'm so sorry. We are totally at time, but I have one more poll again for us to launch, and I will just go ahead and close. But thank you so much for your questions and this great discussion. I don't want to stop it. So I know that Jessica, David, and Dr. Mera's, just all their contact information is in the chat, and we will definitely provide that if you have any follow-up questions on these important topics for sure. So let me go ahead and launch this poll so you all can answer it. Again, it's just about 3 questions, so we'll give you about 30 seconds to answer. And also in the chat, we do have our NPAIHB survey for just to get some feedback, so we can provide, any feedback that you would like to provide about your webinar experience, so we can improve as we provide more events. We do have some upcoming events as well. With NPAIHB, if you would like to join. So our upcoming event on the 16th is with our Get It to Vote International Integrated Voter Education National Project Celebration. So that is this Thursday at 1 p.m. EST. And following, we have the NPAIHB Project ECHO, Explore Healthcare Environment Reservoirs and How to Manage this and Spread the Germs event as well. And then we also have a couple more Project ECHO events with NPAIHB, which is Explore the COVID-19 Pandemic as it relates to risk recognition and reservoirs in healthcare event. And we also have our follow-ups, our second session and third session for the Red Ribbon campaign on July 17th and July 26th. So please visit our NPAIHB.org events page for more information on these events, as well as our registration links for those events as well. So thank you so much for participating and just asking all of these questions. Thank you so much to Dr. Mera, David, and Jessica, who I saw just had to leave, for collaborating with us and providing this wonderful event for all of our participants. So thank you so much. We really appreciate you all being here today. And if you have any questions, I will also put my information into the chat box if would like to ask NPAIHB any questions. But thank you again. We really appreciate you all being here today. Have a wonderful rest of your day.
Okay, I'm going to stop the recording.